Hello, everyone. I'm Damian Cabrera, Program Manager for the Treatment Division at NMAC. Thank you for joining us in this webinar. This webinar is part of the Gay Men of Color Fellowship. The fellowship is a program where we train a group of folks for them to develop the messages around HIV prevention, treatment, and stigma, so that they develop messages, images, and everything related to it to make sure that the message resonates with the community, and in line with that idea of empowering leaders and kind of giving the floor to leaders in the community to train and to inform their peers. We're going to have a conversation about the intersections between HIV and monkeypox and how peer-led efforts can help reduce racial health disparities. But before I start introducing the topic, I wanted to let you all know that NMAC is a CDC partner to help them support in spreading the message about the Let's Stop HIV Together campaign. Chip, who is in the background of this platform, will put the link in the chat. There you can find a zip locator to find HIV services around you that include treatment, PrEP, HIV testing, and also you can find amazing resources in Spanish and English regarding prevention, treatment, and also about stigma. So please go and check it out. And now, as I was mentioning today, we're going to have a conversation centered about how leaders can inform their peers as we have a new kind of arising public health issue that is impacting disproportionately gay men, particularly gay men of color. So we're going to start with Greg Millett, who is the Vice President and Director of Public Policy at AMFAR. He will be providing a kind of a state of monkeypox throughout the U.S. and also a clinical update. Greg is an epidemiologist and researcher with significant experience working at the highest levels of federal HIV policy development at both the White House and the CDC. And from 2009 till 2011, he served as Senior Policy Advisor in the White House Office of National AIDS Policy. Prior to being at AMFAR, he served as the HHS CDC liaison for the White House. And also, aside for the extensive research that he has done around Black men who have sex with other men, he has also been very involved in doing research around disparities and around monkeypox. And actually, we are going to put also a link on the chat where his most recent publication called Monkeypox Research Gaps, What Remains Unknown. This was recently published, and it's also going to be part of it's going to be on the chat. We're also joined by Daniel Driffen. Daniel is also working with us at NMAC to make sure that Black/African American men who have sex with other men are represented in terms of how the monkeypox has been disproportionately affecting that population, and myself regarding the gay MSM Latinx folks. Daniel Driffen is the co-founder of Thrive Support Services, a patient advocacy and social support network based in Atlanta, Georgia, offering resources for Black MSM living with HIV to achieve better health equity. In addition, Daniel has served as co-chair of the Fulton County HIV/AIDS Advisory Committee. Driffen holds a Master of Public Health from Morehouse School of Medicine, focusing on identifying and creating community-driven, innovative solutions to improve health outcomes among men who have sex with other men, particularly men of color. So as you can see, we are joined by experts today. I am super excited for this webinar, and now I'm going to pass it over to Greg.
Great, thank you, Damian. Welcome, everybody. I want to make sure, can everybody see my screen and my slides?
I can see, no, I cannot see your presentation.
Okay, it's open somewhere. Let me see if I can find it for here. Can you see it now?
Yes, yes.
Okay, for some reason, it is not I don't know what's going on, but I can't, the whole presentation is,
Yeah, I cannot see the whole slide.
yeah, the whole slide is, I don't know what's going on with that. Chip, I might need some help from you on this because I've not used this platform before and it worked when I opened before. Let me see. Try it one more time. Can you see it?
I can see it in presenter mode, but I can see it. That's perfect. Yeah.
Okay, terrific, great. All right, thank you everybody for bearing with me as I was just trying to pull everything together. I wanted to thank Damian as well as NMAC for the opportunity to talk a little bit about this new monkeypox outbreak that we've been dealing with for the last several months, and it's really an honor to be here with my co-presenter as well, Daniel, who is a really good friend and someone that I actually see quite a bit now here in Washington, D.C., doing some fantastic work. So in terms of the overview, some of the things I want to talk about today was, really quickly what monkeypox is, what it's not, how it's affecting our communities, and some of the things that we can do. So in terms of what monkeypox is, it's a virus that's part of the orthopox family. And these include viruses such as chickenpox, smallpox, cowpox, horsepox, all are part of the same family. The symptoms for monkeypox is a headache or muscle aches, chills, having a sore throat, nasal congestion. Sometimes you'll see a rash or lesions as well as fever. And the way that it's transmitted, like many other types of viruses, including HIV and COVID-19, is that the first transmission of it is really from animals to human. And it's transmitted from rodents, sometimes from primates, such as chimpanzees in rainforest areas of West Africa and Central Africa. It's located primarily, or traditionally, has been disease that we've seen in West and Central Africa, and it was discovered well over 50 years ago that we've known about it. But it's been rare to have any type of transmission outside of the African continent. That's why what's taking place over this summer is something that really has taken a lot of us who are epidemiologists by shock, because we've never seen an outbreak like this before. And one way to try and frame this outbreak is that, quite frankly, it is part of quite a few outbreaks that we've been dealing with for quite some time. So from 2015, we've always had HIV and STD. But in 2015, you might remember that we had an outbreak of HIV among opioid users, and that there was co-infections with hepatitis C, and it was one of the largest hepatitis C outbreaks we've seen. In 2016, another mosquito-borne virus, Zika, where we saw quite a few infections in the United States, and particularly affecting women who are pregnant. In 2018, we had the measles outbreak, where many kids were not able to go to school because they were not properly vaccinated, and you were seeing large communities of people who had measles, particularly in New York City, in my old neighborhood in Brooklyn, where you saw quite a few people who had measles. And then from 2020 through now, 2020 through now, we've seen COVID-19. COVID-19, of course, over 7 million people have died from it worldwide. In the US, we've already had over 1 million people who've died from COVID-19. It's this other infectious disease added on to HIV and STD. And unfortunately, this year, we're seeing many other infectious diseases that are emerging and re-emerging. So we've always had polio, but the fact that a disease that we had already vaccinated against is now reappearing in New York City. We have an outbreak there. There's been outbreaks that we're seeing in London and the UK as well. We, of course, had a meningitis outbreak this summer, primarily among Latino gay men in Florida, where well over 12 people had died from this meningitis outbreak. And then, of course, the latest one, the one that we're talking about today, just in this year, is monkeypox. So we're seeing this rash of infectious disease and infectious disease outbreaks over the last several years. So what is monkeypox? What is it and what is it not? Well, in terms of what it's not a new disease. As I mentioned beforehand, this is a disease that we've known about for well over 50 years. It's something that the scientific community and others know about. It's just that it's behaving differently this time. The vaccine is also not new for monkeypox. The Jynneos vaccine and other vaccines have been created quite some time ago, and some of it has been stockpiled within our smallpox response. And monkeypox is not deadlier or more contagious than COVID. What we dealt with COVID-19 was much more contagious. It was airborne. It was quicker moving in terms of the number of people that it affected, and it was definitely far more deadlier than what we're dealing with monkeypox. We're lucky in the United States where there's only been one recorded death that's confirmed for monkeypox, and maybe one other that may be associated, but we're not sure yet. We also know that the monkeypox vaccine was not created in a lab. We hear this all the time from people in our community. We've heard it around HIV, we heard it around COVID-19, that this is all created in a lab. It's not. This is something that is a part of what happens when the climate changes. It's a part of when humans enter habitats that we see with deforestation in jungles, and you come in contact with animals that have particular viruses, and those viruses get passed on to us. We also know that the monkeypox vaccine is safe. This is a vaccine that's been around for quite some time. It's been used in other settings, and it's certainly something that is safe for human beings. However, monkeypox is not chickenpox. And we hear from a lot of people that, oh, well, I had chickenpox when I was a kid. That's not going to protect you from monkeypox. I also had chickenpox as a kid. My husband, many others had chickenpox as a kid. That's not what's going to protect you from getting monkeypox. We also hear that monkeypox is a sexually transmitted disease. And I can understand the confusion around that because it is sexually transmitted. We're seeing sexual transmission as the main way of getting monkeypox, but it is not a traditional STD. Before this outbreak, monkeypox was primarily circulated through surfaces, people touching common areas within households in different parts of Africa, or people who are, happen to have lesions on their bodies, and even in a different, if you're in a household, if you're rubbing up against one another in a particular way, that was a particular way that it was transmitted, not sexually. So this is different. And it is okay to get vaccinated against monkeypox virus even if you've been exposed. So some people are saying, well, if I was exposed to monkeypox or if I had monkeypox, then I shouldn't get the vaccine. That's actually not correct. You should get the vaccine. It could be helpful in helping to further protect you from getting monkeypox again in the future. So now that we know what it is and what it isn't, you know, one of the things that's been a surprise for us was just how quickly monkeypox spread. The outbreak was in the United States. Back in early July, when there were only 800 cases of monkeypox, my colleagues and I here in AMFAR were taking a look at how many cases were increasing from the first cases that were diagnosed in early June to early July. And we just wanted to see, well, when we get to August, how many more cases are we going to have? So by the time that we did this analysis, there were about 800 cases of monkeypox in the US. And we said, well, you know, by August 4th, we're going to see 11,000 cases. Other people told us there's no way that that's going to happen. There's no way you're going to see that much within a month's period of time. But it did happen. We saw this 14-fold increase in actual monkeypox cases, not by August 4th, but by August 12th, where we actually crossed the threshold of 11,000 cases. So we were only off in our projection by a week. And what this looks like is that, you know, May 18th was the first time that we've had the first case of monkeypox. By May 26th, there were 10 diagnoses of monkeypox. By June 16th, 100. By July 13th, 1,000. By the end of July, it went from 1,000 to 5,000 diagnoses. By August 10th, it doubled from 5,000 diagnoses within just a couple of weeks to 10,000. And then by September 2nd, we had 20,000 diagnoses of monkeypox. So what we're dealing with right now is something that has just increased exponentially. Right now, we're at 25,000 diagnoses of monkeypox in the US and about 66,000 diagnoses of monkeypox globally. The good thing is that we see the trajectory of diagnoses, they peaked around that time in August that are showing you some of those data. Now we're starting to see a bit of a decrease in monkeypox diagnoses. But that decrease is not going to be a decrease that we see everywhere. Just like with HIV, just like with COVID-19, some of these decreases that we're seeing is mainly because of the decreases that are taking place in the major cities, in New York Cities, San Francisco's, other places that got monkeypox first. What usually happens with infectious disease, as we've seen with HIV and COVID-19, is that it starts on the West Coast and the East Coast, and then it moves to the interior of the country. We saw that with COVID-19, where at the very beginning in March, it started in the West Coast and the East Coast and then started to fall. And then we could see how it started to increase just when it was falling on the East Coast and the West Coast in the middle of the country. That's exactly where we might be with the monkeypox epidemic, is that it's probably starting to increase in other parts of the country. And we're actually seeing that. We're seeing increases in Virginia, we're seeing increases in New Hampshire, increases in Utah, and other parts of the United States. So we're waiting to see whether or not these diagnoses are going to continue to come down, or are we going to still see these little spikes of it coming up because we're seeing these regional increases in monkeypox. The other thing that we see with this monkeypox variant, which is particularly different from what we've seen in African countries. In African countries, you see an equal number of men and women essentially who are getting monkeypox in Nigeria and other parts of the African continent. Here, as well as in Europe, we're seeing that the overwhelming majority of cases are among men, and then the overwhelming majority of cases among men are among men who have sex with men. And we're seeing very few cases among cisgender women, and they're also seeing few diagnoses as of yet among people who are transgender men or transgender women. And this is something that they're seeing in Europe, they're seeing it here, where it's a very similar pattern. The other thing that we see that is different from what has taken place with the outbreaks, the many outbreaks that we've seen in Central and Western Africa over the last 50 years, is that the symptoms for monkeypox are not always noticeable with this outbreak. So the outbreaks that we've seen in many African countries, I'm sure that you guys have already seen all over the media, people who have, pustules and lesions all over their bodies. That's not really something that we're seeing with this new variant. We're seeing very small types of things that almost look like mosquito bites or pimples, where some people are getting, these monkeypox lesions in their mouths, but it's something that you could easily think is just a canker sore and not monkeypox. People have things that look like pimples, or even just a mosquito bite. And not really realizing that this is actually monkeypox. So there are some symptoms that are not going noticed, and some people who are probably not being diagnosed because they don't realize that they have monkeypox, and they might unwarily be transmitting it to other people. The other thing that we're seeing that's a part of the US monkeypox outbreak, as well as the Mpox outbreak in Europe, is that there are a large proportion of HIV positive individuals, gay and bisexual men, who are getting monkeypox. In terms of men who have sex with men, we are perhaps about 20% of men who have sex with men in the US, but we represent about 40% of the monkeypox diagnoses. And it's not just the US where we're seeing this 40%. We're seeing it in Europe for some European CDCs reporting about 40%, in Spain about 40%. There's a New England Journal of Medicine article about 16 countries in Europe where it's about 40% of monkeypox diagnoses are among those of us who are living with HIV. And the World Health Organization globally is also finding in this current outbreak that it hovers around 40%. And a lot of people are asking, what is it? What's taking place as to why HIV positive men have such large numbers in this monkeypox outbreak? Some of it might be because we go to see our doctors more often than other men who have sex with men. Some of it might be that it's just in a network of men who have sex with men who are HIV positive that we've seen monkeypox. Another part of it might be that we're more susceptible to monkeypox. But these are all questions that scientists are trying to figure out. One thing we do know is that if you are HIV positive and if you have monkeypox, you are going to have symptoms of it that are going to be very similar to people who are HIV negative if you are virally suppressed. However, if you're not virally suppressed, the symptoms for monkeypox can be really bad. It can be just incredibly bad. And here is an example of a man from Germany who had HIV. He was never diagnosed with HIV. He never went to get tested for STDs either. They found out that he presented to the doctor with what looked like sunburn on his nose within 3 days. His nose actually started to deteriorate. The whole cellular structure of his nose started to die out. They actually have to reconstruct his nose. When they tested him, they found out that he had syphilis. For a long period of time. He was never diagnosed with it. He never went to an STD clinic. And he was also HIV positive with a very low CD4. And what this case really illustrates is how severe monkeypox infection can become if you are HIV positive and untreated. And this is a type of person, when we talk about 90, 90, 90, and we keep thinking about the 10, 10, 10 that we're not getting, this is a type of person who's part of the 10, 10, 10 that we need to reach if we're going to end HIV, but more importantly, if we're going to make sure that people don't have bad reactions to diseases such as monkeypox. There's other issues that we're seeing as well for people who are immunocompromised and have monkeypox. So CDC released data recently where they're looking at hospitalizations between HIV positive men versus HIV negative men who had monkeypox. And they found greater rates of hospitalizations among those of us who are living with HIV. And more importantly, as I mentioned beforehand, the few deaths that we had here in the United States, there's one confirmed death and one other death that might be related to monkeypox. But those 2 deaths are among people who are severely immunocompromised. So this is another reason why, for those of us who are living with HIV, that you need to make sure that you're getting tested for monkeypox and getting put on vaccines and treatment as soon as possible, because it can be far worse for us who are HIV positive, and particularly those of us who are not virally suppressed. The other thing with monkeypox that is pretty interesting as well is that unfortunately the symptoms are very similar to COVID-19. They're very similar to having acute HIV infection when you just become infected with HIV, such as swollen lymph nodes, headache, fatigue, sore throat, fever. All of those things are common for each one of these 3 diseases. So sometimes people can get confused, your clinicians can get confused in terms of what you might have. And sometimes people are being diagnosed with all 3 diseases. This is an example of a man in Italy just a few weeks ago who went to a party, traveled to a party in Spain. Within 9 days, he came back with these symptoms. And when they tested him, they found out that he not only had HIV, newly diagnosed with HIV because previously he tested negative recently, but he also had SARS-CoV-2, COVID-19, as well as monkeypox. So this is part of the viral storm that we're dealing with, where all of these infectious diseases are present in our ecosystem, and where you can find that among some of us, particularly those who are marginalized, you can get every single one of these diseases and illnesses at the same time. The other thing that we're seeing with these illnesses is that we're seeing a high rate of STI and STDs. And these are data from CDC that they published last week, and they showed to the rest of us to see the proportion of people living with HIV and the people who had monkeypox who also had STDs. So among those who were diagnosed with monkeypox, 41% had an STD in the past year. Among those diagnosed with monkeypox and were HIV negative and on PrEP, 67% of them had an STD in the past year. Among those who were diagnosed with monkeypox and HIV positive, 38% had an STD in the past year. And then among those who either had HIV or a recent STD, 61% of those were diagnosed with monkeypox. So we're seeing this interplay between monkeypox and STD. The other interplay that we're seeing that is very similar with HIV is that specific racial and ethnic groups are more likely to be diagnosed with monkeypox, just like specific racial and ethnic groups are more likely to be diagnosed with HIV. So many of you are familiar with these slides from CDC showing where new infections were for HIV in 2019. And it's concentrated among Black as well as Latino men who have sex with men, as well as white men who have sex with men. And then among heterosexuals, it's concentrated among Black men as well as Latino men and women. So that's really where we see HIV for like the last 15, 20 years. It's really been in these populations. Unfortunately, we're seeing those same racial dynamics when it comes to monkeypox. CDC released other data last week that were really quite shocking. When you look at monkeypox overall, they're saying about 40% of those diagnosed with monkeypox were HIV positive. But then when you look by racial and ethnic groups, you see something different, where you see among Asian men, Among Asian men, about a quarter of those diagnosed with monkeypox were HIV positive. Among white men, about 30% of those diagnosed with monkeypox were HIV positive. Among Latino men, 40% of those, 4 in 10 of those diagnosed with monkeypox were HIV positive. And among Black men, 6 in 10, 60% of those who were diagnosed with monkeypox were HIV positive. So we're seeing really huge proportions of those diagnosed with monkeypox who are HIV positive, and you see that really come out by race and ethnicity in many of the results that are out there. The other thing that we're seeing too is that monkeypox diagnoses are becoming more Black and more brown over time. So these are data that CDC had from May of this year through August of this year, and looking at the race ethnicity of monkeypox diagnoses. And you can see in blue, these are the proportion who are white. And in May, you could see that white gay men were the main numbers of monkeypox diagnoses. But then take a look at the green, which is Latino men, and then the purple, which are Black men, and look at that over time, where you see that green and that purple really becomes most of the diagnoses that are taking place, where now we are more than 2/3 of the diagnoses for monkeypox in any given week. The disease has become much more Black and brown over time, and we've seen the same thing happen with HIV, which has become more Black and brown over time, and exactly the same thing that's happened with COVID-19. And just like with COVID-19, we're seeing that Black and Latino MSM are less likely to access vaccines, despite the fact that we're at greater risk for monkeypox infection. So you see here that white gay men are 30% of monkeypox cases, but they're getting 50% of the vaccine. Whereas for Latino gay men, 28% of cases, only getting 24% of the vaccine. For Black gay men, 38% of cases, only 13% are getting vaccines. So we're seeing these major disparities in terms of getting access to vaccine, exactly the way that we saw that with COVID-19. So we did not deal with that issue with COVID-19. We're seeing it over and over again now with monkeypox. We're seeing the same thing too in terms of treatment. The treatment for monkeypox is TPOXX. And we're seeing that for white gay men, even there are only 28% of monkeypox cases, 38% of them are able to get treatment for monkeypox. For Latino gay men, 28% of cases, but only 22% are able to get treatment for monkeypox. For Black gay men, it's the same thing, 38% of cases, but only 32% are able to get treatment for monkeypox. And we saw the same thing for COVID-19 with CDC releasing data showing that for monoclonal antibodies, which is one of the treatments that you have for COVID-19, that over the period of time, all of last year, that whites were more likely to get access to this treatment as compared to Blacks or Latinos. So this is something that unfortunately is something that plays out over and over again, that the communities that need it the most are less likely to have access to prevention or to treatment. And this is, of course, something that we saw with HIV, where, and I've shown this chart many times, where as soon as ARTs became available, that the mortalities between Blacks and whites actually increased because Blacks were far less likely, if they were HIV positive, to have access to ART as compared to whites. And then we're seeing the same thing too right now with PrEP, where despite the fact that Blacks and Latinos are more likely to be HIV positive or be at risk for HIV, we're far less likely to access PrEP. Only 8% of African Americans, 14% of Latinos, as compared to 63% of whites who are accessing PrEP. The other thing that we're seeing too that is very similar to what we've already seen with HIV and COVID-19 is that there always has to be someone to blame whenever you have a new infectious disease outbreak. And we're seeing that right now as well with monkeypox, where people are, blaming gay men for monkeypox. We saw here in Washington, D.C., a gay couple that was attacked. This was something that I saw on Twitter of a Latino gay man who was getting back on a plane, going back home to Palm Springs, and the person next to him on the plane when he sat down said, "Do you have AIDS or monkeypox?" And when the guy refused to engage with this man who just asked this question out of nowhere, he actually got up and changed seats. So, this kind of homophobia coming out of nowhere. The other thing that people are not discussing a lot about is the fact that because monkeypox is primarily affecting Black and Latino gay men, that these are men who are less likely to have the resources to stay and isolate if they get monkeypox, to stay at home for 3 weeks. So this could really financially ruin many of these individuals. And we're seeing, lots of GoFundMe pages going up, people who are trying to figure out ways that they can pay rent, people who are figuring out ways that they can get food when they're not going to work because they have to self-isolate for 3 weeks if they get monkeypox. So we're seeing these financial aspects, and it was the same financial aspects that we saw with COVID-19 when the country closed down. Who it hurt more were Black and Latino individuals in terms of being kicked out of jobs and not being able to find work, and then financially being in a really dire straits. So we're seeing the same thing with monkeypox. The other thing that we're seeing is that knowledge gaps of the vaccine are really not uniform for all men who have sex with men. So the good thing that we're starting to see is that in terms of the monkeypox doses, the dark blue is people who are getting their first doses. And the light blue are people who are getting their second doses. So we're starting to see as time goes by, many people are getting their second doses, but still there's a lot of gay and bisexual men, particularly Black and Latino gay men, who don't realize that this is a 2 vaccine dose, that you have to get both of them in order to be protected against monkeypox. And that's something that we're gonna have to deal with. The other issue is that we also see some gay men who don't know when they can engage in specific behaviors again once they get the vaccine. So this is just from Twitter. You know, a young Black gay man here in Washington, D.C., who's asking everybody on Twitter, you know, I need to get this monkeypox vaccine before I go to Provincetown this weekend. It would really stink if I had to limit the number of things that I wanted to do while I was up there with other guys because I wasn't able to get the vaccine. And he didn't realize that even if he got the vaccine that week, when he went to Provincetown that weekend, he wasn't going to have any protection from monkeypox. That it takes at least 2 weeks to get some sort of protection from the monkeypox vaccine. And even when you get that protection for 1 dose, it's only 30% protective against monkeypox. You really need the second dose so that you could at least be more than 80% protective against monkeypox. So we're still seeing that these gaps are there. The other thing that is interesting to see is that, you know, gay and bisexual men are reducing their risk of getting monkeypox. And CDC released data showing that, you know, among gay and bisexual men who are hooking up on a daily basis, they're less than 3% of these total, you know, sexual partnerships that take place each day. But those less than 3% account for 50% of monkeypox transmissions that take place on a daily basis. And CDC was saying that if there was a 40% decrease in one-time hookups among gay men, that would reduce monkeypox diagnoses by 20 to 30%. And that's actually something that we're seeing. We had other data from CDC showing that gay men are reducing the number of sex partners. 48% of the people said that they've done that. About 50% said that they've reduced their one-time sexual partners. 50% said that they reduced meeting partners on sex apps like Grindr or Scruff or Adam for Adam, etc. So you see the community responding. And that's part of the reason why we're starting to see this decrease in New York City, is because the community has been responding and has been taking matters into their own hands. And this is something as a HIV community that we already know and that we've done before. You might remember that in the early 80s, before we had behavioral interventions, before we had PrEP, before we had ART, that we saw new infections really spike in the mid 80s for HIV. And then they started to come down by about 1987, 98, 89, all the way to about 1990, where the number of infections really came down. And that was all because gay men were reducing some of their risk behaviors. They were doing particular things to make sure that we could reduce the numbers of HIV. And we've done exactly the same thing again with monkeypox. The other thing that you see too is a lot of resilience in the face of stigma and disease, which is good. We're seeing a lot of gay men who came out this summer. They got on TikTok, they got on Twitter. They're talking about their experiences with monkeypox. They were really trying to rewrite the narrative and stigma that's out there about monkeypox and feeling shame for getting monkeypox. And they were talking about their disease openly. And you're also seeing gay men who are talking openly about getting the monkeypox vaccine, outing themselves to their employers and their peers, saying, yeah, of course, you know, I might be at risk for this, and I want to make sure that I'm taking care of myself and getting vaccinated. And this is something that we saw even just a couple of years ago. You remember how controversial PrEP used to be, and people who were being called Truvada whores, and folks who were, you know, really taking that name back and really reclaiming it and saying, yeah, I'm in charge of my sexual health. Of course, I'm going to take Truvada. Of course, I'm going to take care of myself. And that's exactly the same spirit from then that we're seeing now in terms of people who are fighting stigma and rewriting the narrative. One thing, though, that I do think that we should definitely discuss is that it's not just about the monkeypox outbreak now that we have to worry about. We have to worry about the long-term consequences of monkeypox. Monkeypox has been shown to cause heart problems. The problem is that we're in an era of COVID-19, and having even mild COVID is associated with heart problems. And we also know that HIV and HIV medications is also associated with cardiovascular disease. So what does this mean for those of us who are living with HIV? If you had COVID-19, if you got monkeypox, how does this in the future look for you in terms of chronic disease such as heart problems, diabetes, other issues? And these are things that I think as researchers, as well as activists, as well as clinicians, that we have to keep an eye on to see how all of these viral storm that we're dealing with is perhaps worsening some other outcomes for people living with HIV down the road, not just here in the current day. So this gets me to how you can assist. How can CBOs respond to the monkeypox epidemic? And there's several things that you can do. The first thing is I said that, there's an awful lot of things that are wrong out there, people that don't understand the facts about monkeypox. It would be great for you to help us communicate about monkeypox. What are the facts? How can you get it? How can you not get it? To fight some of the stigma that's associated with having monkeypox, to let people know that there's no shame in getting monkeypox. The next thing is to help in finding places for people to test, to get vaccinated or treatment services, or to provide those services yourself in testing, vaccinating, and treatment. The great thing about CBOs is that you have access to the populations who are most at risk, particularly right now for monkeypox, and they trust you. So you would be great venues for testing, vaccines, treatment, etc. I think the next thing that CBOs can do and peers can do is to really help share some of the best practices in reaching the most vulnerable, best practices in stigma reduction or communication and translation of monkeypox facts is some things that will really be able to help us in reducing the number of infections in this epidemic. And then last, I think another way that CBOs as well as peers and others can help is if you can help be the eyes and ears in some ways for public health agencies. We don't know if the number of diagnoses are going to continue to go down. If you're starting to see diagnoses increase in your region of the country, if you're seeing diagnoses increasing in particular communities where we haven't seen them before, such as trans populations or homeless populations or others, to really help in letting some folks know at the health department or CDC or the State Department of Health that, hey, we're seeing that these diagnoses are actually starting to jump into other communities, and we need to get on top of this so that we can keep this from getting any worse. So thank you for the opportunity to present, just trying to give you some comprehensive information in terms of the outbreak, where we're at, the ways that CBOs and others can help, and looking forward to working with you as we actually end this outbreak in the near future. Thank you.
Thank you so much, Greg, for that comprehensive presentation. We were going to pass it over to Daniel, but he had some difficulties on his end and had to disconnect from the call. But I wanted to, and by the way, Greg, I don't know if it is only on my end, but your camera seemed to be frozen. So if you can turn it off and on to see if it, yes, perfect. Now, great. And then, yeah, so there were a couple of things. And by the way, everyone that is for the attendees, please make sure that you put your comments on the chat box, and Chief from Communications will be reading them out loud. But before we go to the Q&A, there were a couple of things that resonated with me, particularly what you were mentioning about the viral storm, right? First HIV, then COVID, now monkeypox, and we have seen how these disparities kind of keep repeating themselves. It seems that that there's still a lot to learn from all of these experiences. But from what I have seen from the community and the data that you showed is essentially how how peers, how the community has actually taken upon themselves to talk about it, to inform others, and we have seen how it has turned out. So I think it also speaks about how peers and not only talking about peers about only individuals, but also, as you were mentioning, organizations have an essential role in being those trusted messengers to pass along this information to other community members, as we have seen a lot of gaps in terms of communication, particularly to our communities. And you were also mentioning about not only the lack of information around our communities, but also something that really resonated with me and that I heard so many times during COVID, particularly around Latinx communities, is that isolation might not be an option. And if people have to isolate, that has, you know, enormous implications to their economy or to how they survive, right? That there are sadly there are no systems, or the systems of support are not necessarily there to cover for everything that people of color actually need.
Absolutely. And I think the other thing with isolation too is that, people are assuming that you can isolate and that you have a house that has multiple bedrooms. And if you have roommates, everybody has, their own bedroom and everything is fine. That's not the reality of most people's lives. Most people, you have 2 or 3 generations in maybe one room or 2 rooms, and, you just can't isolate. And of course, you are afraid that you might, give COVID, you might give monkeypox unintentionally to some of your family members. So that's another concern too that we see in communities of color as compared to other communities. So not beyond just the financial aspects of not being able to go to your job for 3 weeks, and what that means in terms of what you do financially. So that's one of them. And in terms of what you were saying, for the gay community response and the CBO response, the wonderful thing about our community is that we have muscle memory. We've done this before. We've done it with HIV. We're at the point right now where we're talking about ending HIV, which is incredible, something that I never thought we would be thinking about back in the 80s when I was a kid. And we've done it not just with HIV, we've done it with STDs, we've done it with MRSA and the MRSA outbreak that took place. We've done it over and over again with different types of outbreaks and infections. And that's why I think with monkeypox, the response was so quick in our community, with the CBOs mobilizing, with people getting information out there, with talking about how you can and can't get it. It was, almost important just to have that muscle memory and that infrastructure that we already have with our CBOs, with our peers, to really make sure that we take care of ourselves, because we could not always rely on the government from the very beginning of the HIV epidemic. Whoop, Damian, I can't hear you.
Yeah, and I also think that
I can hear
can
you
you
now.
hear me now? No? Okay, perfect. Yeah, I was saying that one of the things that might be impacting the vaccination rates that we have seen, or the disparities that we have seen, is hesitancy, right? And one of the things that I think is important for us, and us meaning peer educators and organizations, is to be transparent about how data might change in the future. For example, we have experienced this during COVID, right? At the beginning, it was the best data that was available, as we have now, and then things were kind of adapting as more data became available. And I also think that being transparent about, for example, the secondary effects of vaccination. For example, in my case, I got my second shot on, I would say, like 5 weeks ago. I still have the mark, and I don't have a problem with it. But I'm sure that since it is highly stigmatized, not only because we are gay, but also because we are sexually active, that it might pose a barrier for many other people, particularly men who have sex with men that are not necessarily open about their sexuality. And we have to be clear about that too.
Yeah, I think it's a double-edged sword. I think, that for some people, they'll see, these marks of where the vaccinations are, and they say, hey, I got one too. This is great. We're both taking care of ourselves. And then some other people who will say, hey, you're outing yourself as gay, and this is probably not a cool thing. I think the thing that we have to keep coming to terms with is that the same populations who are at risk for HIV, who are not in care, who are not getting tested, are at risk for monkeypox and really worse outcomes from monkeypox. So, for instance, I was just on a call with the European CDC today, and they were taking a look at men who have sex with men in Europe who had HIV, but they haven't been treated for their HIV, they haven't been in care for HIV, etc. They found that those men were far less likely to get the monkeypox vaccine. So, men who are HIV negative on PrEP, men who are HIV positive in care were far more likely to get the monkeypox vaccine. Those who had never been tested, like the guy that I showed you in my presentation, were far less likely to get the monkeypox vaccine. And that's kind of scary because if you have untreated HIV and you're not getting vaccinated, the outcomes can be really bad in terms of not just clinical outcomes, but even risk of death. So that's why it's important for all of us to really come together to show the benefits of getting tested, not only for HIV, but for monkeypox, and then more importantly, if you're HIV positive, getting onto treatment as soon as possible for your sake, as well as the sake of many others, and then to get vaccinated for monkeypox to make sure that you can live a happy and healthy life and not worry about something else. So we just have to keep spreading this among our community.
Yeah, and I think that it also speaks about how do we adapt the messaging and how do we adapt the interventions to make sure that we reach, the diversity within the diversity, to make sure that we reach everyone. So I think that's a very important point of what you were mentioning. So I want to make sure that we allow for the audience to ask questions. Chip, do we have anything on the chat box?
No questions yet. I just put out a request for questions. But yeah, if anybody has questions, please put them in the questions box.
Awesome. And Greg, I wanted to ask you because what we have learned a lot, not only from monkeypox, but also COVID and HIV. How do we make sure that that this is sustainable? That what we have been learning now during monkeypox can be applied later for anything that comes up later that might surprise us, and also even to HIV. How we provide sustainability to these efforts.
Yeah, I think that there's a couple of ways that we do it. I mean, the first is, the good thing about the HIV movement is that we have a lot of leaders in the movement who stay in the movement. So you have that institutional memory that's there to respond to each one of these, outbreaks and challenges that we have, and that's an asset for us. I think the other thing that's important for us as well is that, we've already provided these institutions that can really help blunt the effects of any further outbreaks. The fact that we have, CBOs that are here, that are helpful. We're far ahead of other communities that are affected by specific diseases that really don't have these types of resources. Resources meaning, actually these organizations that are here to help, to provide information, to provide translation, to really help us understand exactly what's taking place and to shield us from the worst effects of it. I think the other thing that we're going to need, though, in the future is that, as I was mentioning before, we're dealing with a viral storm. So our CBOs are beleaguered by dealing with not just HIV and ending the HIV epidemic. You're dealing with, STDs that are going out of control right now. You're dealing with COVID-19 that might come back in the wintertime. We're probably going to have a worse flu season this year than we've had in previous years because fewer people are wearing masks. And then, of course, you have monkeypox on top of that. So we are dealing with CBOs that have multiple balls in the air where essentially they're only funded for maybe 1 or 2 balls at the most. So we're going to need more funding for CBOs to make sure that they can do the work that they need to do so that they can adequately deal with all of these challenges at the same time.
Yeah, absolutely. I agree that the workforce is essentially burnout of dealing with so many things at once. So making sure that the funding is there to hire new people, to train new people is essential. And one of the things that I have been discussing with people from other organizations, and here in Puerto Rico and also in the States, it's also how culturally competent information is put out there. And this is not new. This is something that we have seen throughout, before. But the need to create content in Spanish to make sure that those gaps in information are addressed, because sometimes there's a disconnect, and then we ask, then why are we seeing these numbers in Hispanic men, in Latino men? And if we don't address not only the language but also approaching it with a cultural perspective, it's going to make a huge difference. Being from Puerto Rico here in the island, I can tell you that from my experience is that you can tell when something was just, for example, translated, instead of being put an effort into adapting it how people speak, because I think that's essential when you're transmitting a message, whether it is in English or in Spanish, but to make sure that the message kind of relates or reflects how people speak, to make sure that the message actually resonates and people trust that message, because hey, they are speaking like I do.
Absolutely. And, and we saw that with COVID-19. I mean, there's actually data out there showing that people who are monolingual or who are just English speakers were less likely to die from COVID-19 or to get COVID-19 in certain parts of the US as compared to people who are monolingual Spanish speakers or monolingual speakers of Korean or Japanese or other languages, who did not have access to the same prevention or care messages because none of the information was translated for them. And that's crazy that something like that is happening in 2020, 2022 of the US. The other thing too is that, when I take a look at these monkeypox figures, the first thing that I always think about is when they talk about, Latino individuals who have monkeypox. My family is Cuban and Panamanian. I'm first generation American. And I always wonder, well, who in the Latino community are you talking about who's getting it? Because that's also a difference there too. We've seen with HIV that not all Latinos are at the same risk for HIV. You see uniformly in CDC data, Puerto Rican, Dominican, some Central American who are more likely to get HIV as compared to, say, Argentinian. And so I'm thinking the same thing. We saw that same thing as well with COVID-19. The same groups who are at risk, who are Latino for HIV, were the same groups who are at risk for COVID-19. So my question is, among the Latino population that's getting monkeypox, are we seeing that same pattern again? And is part of that pattern the way that our society is structured, that there are some groups that have access to income, to wealth, to health insurance, even within the Latino community, and others that don't? And in thinking ahead about how do we finally break the cycle on some of these things that we see over and over again, not just translation, but even within our communities, who are more likely to get disease as compared to those who don't.
Yeah, absolutely. I completely agree. And so I would like to give you an opportunity to talk about the recent publication about research gaps. But before we do that and before we close, Chip, once again, are there any questions from the audience?
There are. So I'll pull a couple out here. One is, how can national organizations and local advocates get other medical providers to provide monkeypox vaccines instead of local departments of health? Many departments of health have terrible relationships, lack of rapport with gay and bi men in their communities.
Yeah, I think that you're going to see that the response and the rapport is going to be different depending upon which region of the country that you're in. And this is the thing that I was worried about the most, is when I'm saying that, monkeypox diagnoses might be going down on the coast, but they're starting to go up in the South. They're starting to go up in the interior of the US, where policies and attitudes around homosexuality are very different than what you see compared to San Francisco or to New York City. I think that to try and deal with that, first dealing with organizations who have ties to the national scene, who could probably help in trying to make sure that you get vaccines to your particular locality as soon as possible. The great thing is we have a White House monkeypox coordinator who understands these issues and is actually trying to get monkeypox vaccine into different parts of the country, particularly the interior, to help blunt new infections. So, reaching out even to Dimitri and others in the White House who are part of this effort, and HHS, would also be helpful, because they really want to make sure that they blunt any new cases of monkeypox before they occur, and getting vaccines to places that traditionally haven't had it outside of New York or San Francisco.
Okay.
Awesome.
One other question here. I'm sorry, one other question here. One of the difficulties I've seen is that many Black and brown people in my city at least don't engage with any vaccinations, not even flu. How do we motivate people who avoid healthcare aside from being severely ill or injured?
Yeah, I think that, part of this is exactly what Damian was saying, is that there's a lot of different ways that you convey a message. And to convey a message, you have to have a trusted messenger. You have to have a message that actually resonates with people, that's something that people can identify with, that makes sense to them in their lives. And then you have to convey it in a way that also makes sense to them. It can't be in English if you are a monolingual Spanish speaker. So there are things that we need to realize that, if people are not adhering or listening to these messages or not getting vaccinated, it's not really on them, it's on us. We're doing something that's wrong. Healthcare providers are doing something that's wrong. And we need to do some more qualitative analyses and interviews and asking, well, why aren't you getting vaccinated for the flu or for monkeypox or COVID-19? Is it because you work really long hours and the times for vaccinations don't work with the times that you can't take off work for it? Is it that you need access to childcare so that you can go to a vaccination service? Do you not have access to transportation? Or is it around mistrust issues? We have to figure out exactly what it is that's taking place in specific communities, and then we have to tailor our messages accordingly, and also make sure that we make things as easy as possible for people to get access to these services.
Thank you. Are there any additional questions, Chip?
Yeah, there's one more. It's a comment that someone is hearing, and this may be part of the problem. It's hearing many different answers about how long is the treatment for monkeypox and how long a person needs to isolate after diagnosis. That they're hearing many different answers to those questions.
Sure. So the TPOXX treatment that you have right now is, you take it over the course of essentially a week, maybe just a little bit longer. And then in terms of isolation, the current recommendation is as much as 3 weeks. There are a lot of people, I can tell you, who are not adhering to that 3 weeks period. Exactly, the types of people I was telling you about who just can't afford to be away from their job for 3 weeks. Not to mention the fact that if you are away for 3 weeks, you're kind of outing yourself to your employer that you might have monkeypox if they know that you're gay, and the likelihood that you could be replaced over that period of time. So there are quite a few people who might isolate themselves as long as they know that there are visible lesions that are available, that are out there, particularly if they have lesions on their face or on their arms or something like that. And then once those are gone, they might go to work. For other people who have lesions on their genitalia, quite frankly, the only way that your coworkers are going to be able to get monkeypox, and I'm just saying this, I'm not saying it as a federal official or any other way in an official capacity, but the only way that they're going to be able to get monkeypox is if your coworkers are touching your genitals in some way, either your front or your back. And that's just not possible if you have clothing on. And we're seeing very little transmission associated with fomites, so people who are touching certain things and then picking it up from surfaces, especially if you don't have lesions. So I think that if people primarily have lesions in their genital area, as long as they're on TPOXX treatment and they're starting to see those lesions shrink, and if they're fully clothed, and if they absolutely need to go to work, then I personally don't see any issue with it. Mind you, I'm not a clinician, but I already know from friends who have had monkeypox, from some things that I'm hearing from the European CDC, that people just can't afford to be away for 3 weeks from their jobs. So they're trying to make as much common sense of it as possible.
Thank you for that, Greg. And I want to be respectful of everyone's time. We're 3 minutes over, but I did want to give you just a quick moment, Greg, for you to talk briefly around the recent publication that is going to be on the chat, so people can go and access it. If you can give us a quick overview of what it is.
Yeah, so quickly, I'm a researcher by trade, and one of the things I was interested in is that this variant of monkeypox is behaving very differently than the monkeypox that we've seen in Central and West Africa, and it leaves a lot of questions for us. Some of the questions are epidemiological questions, some of them are clinical questions, some of them are social behavioral questions. So some of the epi questions that we have is, how different are we going to see monkeypox in terms of the clinical manifestations for people who have uncontrolled HIV versus those who don't? And what are some of the ways that we can blunt that? Among those people who are returning for their second doses, are we seeing differences by race and ethnicity? Are Black and Latino men less likely to get their second dose? And what does that mean in terms of getting a mutated virus of monkeypox that can be worse at some point? And then many clinical questions that are out there as well in terms of TPOXX treatment. Can you use TPOXX as actual prep for monkeypox rather than just being treated for it, and seeing if we could have clinical trials around that? And then, of course, the social behavioral questions. When you take a look at Black and Latino men who are more likely to get monkeypox, is it about our networks that's placing us at greater risk? And if they're placing us at greater risk, then what about our networks can we use or utilize that can prevent us from getting monkeypox or any other of these infectious diseases? So just some really nice research to try and figure out how we can keep this from happening again, and how we can further reduce monkeypox outbreak in Black and Latino communities.
Awesome. Thank you so much for that summary. It seems that, filling those research gaps can also provide a lot of information for HIV and other challenges that might arise. So thank you so much. Thank you so much for your time and for all the attendees. Apologies for the small technical difficulties, but thank you all for being here. And again, Greg, thank you so much for your time. I really appreciate it.
Thank you.
Thank you. Bye.